Um, so hi all, welcome to the third session of our RaCEEs course. So today we are going to look at the cost side of it. So Valerio cannot be here, so I'm running this session with Ryan. So it's so as you know, Ryan is joining us this year with this RaCEEs program. So yeah, and today we have the help of Ryan in this his first part talking about the costs. So Ryan, please just go on to the next slide. So you have seen that we have our plan for our sessions. So we have that in session one you saw how to choose your paper, your research question, the selection of the economic evaluation, and then we went on to the methods. So in session two, it was very a complicated session. A lot of things for you to know, but they were about the key attributes of an economic evaluation, mostly the models that are used in order to do the economic evaluation. So today we are going to look at the costs, still in the methods. Then next session is going to be about the outcomes, what we measure in the economic evaluations. Then session 5, it's going to be about the results and sensitivity analysis. Then session 6, the Q&A session, which is also a little bit of information on how to do the introduction of the cost effectiveness analysis. And then last of all, the face-to-face workshop where we are going to be together, all of us and each team with their paper. We are going to try to analyze it to do the quality assurance, let's say, the critical appraisal, and produce a commentary. So Ryan, please.
Oops, sorry. Yep.
Okay. So we are still in the method section. Which is basically all these sessions between 2 and 4 are going to be about the methods. We saw the key attributes. Now it's the costs, and then it will be the outcome data. So it is. It's funny because we are spending a lot of time with the methods, and then you will see that in the commentary, it's actually going to be the smallest section. But it is fundamental because you need to understand the methods in order to understand the economic evaluation, in order to then do the critical appraisal and produce the commentary. So it may feel a little bit weird that then it is going to be such a small section, but you cannot do the other sections of the commentary fully if you don't really understand the methods, which end up being the most important parts of the economic evaluation. So again, we are going to have the results in session 5, a little bit of the introduction. We are going to talk about it in section 6, and then we will write our commentary. And with that said, let's start talking about costs, and I'll leave you to Ryan.
Thanks, Luís, for that. Hello, everybody. So yeah, I'll start talking through some of the lectures with you. The aim of this is going to be identify and describing the characteristics of cost data used in economic evaluation. And we can break that down to our total costs, resource use, individual unit cost, and then currency and price here. Get into it, that'll all make more sense. And I think the first thing we need to look at is economic evaluation as a whole. Kind of what alternatives and what choice is being presented to providers of healthcare, and why are they doing these evaluations. So broadly speaking, if we can imagine we had a very simple choice between alternative A and alternative B, there's going to be costs associated with each of those alternatives, and we're also going to get different consequences with each one. When we do the evaluation, though, we have to look at the costs and the consequences at the margin. And what we mean by that is essentially the difference in cost or the additional cost. So it's important that we look at, say, if alternative A is slightly more expensive but gives us slightly better outcomes, we need to look at the additional costs associated with alternative A and the additional health benefits associated with alternative A. And that's kind of called analysis at the margin. And it gives us a more representative result than if we tried to just look at total costs and total consequences compared to each other. So calculating total costs. First, we need to identify resource use. So the kind of number of each unit we use, and then the individual costs of each of those units. And typically, if you imagine just like medicine, so kind of how many times do you have to take a medicine a day, and what's the cost of each one of those units of medicine, and multiplying together will give us our total costs. And then kind of types of costs. Broadly speaking, we've got direct and indirect, and if we break down some of the direct medical costs, they're strictly linked to the direct provision of healthcare. So we've got generic care costs, inpatient care, outpatient care. You kind of might see that expressed as, I don't know, like, the typical cost of staying a bed day in the hospital in the NHS, the cost of all our medications, consultations with GPs in an outpatient setting, and then maybe kind of specialist consultations as an inpatient setting. More kind of complex procedures and treatments, intubation given an example here, different tests, radiology, blood tests, etc. And then kind of other direct medical services that you wouldn't bundle in with generic care. So stuff like rehabilitation from physio or OT, speech and language therapy. We have to kind of plot the whole patient journey and then average it out to figure out what our total costs are going to be. There's also direct non-medical costs, and they're broadly linked to the provision of healthcare, travel accommodation, food, etc. You can see here. And then there's indirect costs. That is, I suppose, costs associated with an illness or a provision of care that doesn't come under the NHS really, or social services directly. So patients themselves can have a lost income when they're sick. So can carers and family members, and lost productivity, lost work days as well. And you also might have in there as well that, people give their free time to look after their loved ones when they need to, and that again is kind of an indirect care cost. And these all come under different perspectives and outlooks, but we talk about that in a bit as well. Oh, actually, that was I think we spoke briefly about perspective last time. Whether you look at it from a payer perspective or from a kind of a healthcare perspective or a societal perspective. If you were to try to group these ones within the NHS, the payer perspective and healthcare perspective is pretty similar because we've got a single provider of healthcare really. So kind of all your direct medical costs will come under the NHS, and that would be healthcare related costs in terms of perspective, and then societal perspective takes into account all the NHS healthcare costs, and then those indirect costs as well that bear a more societal burden. So if we look at resource use, refers to kind of healthcare, staff time, facilities and consumables. Staff time, think of it as probably the amount of hours, the amount of contacts that a healthcare worker would have to put in. So how many times, how much physio they get, how many hours of direct medical care from a doctor. Consumables, again, we can look at kind of medicine, for example, or different bits of consumable equipment we might have to use. We're looking after somebody. And I think facilities is best looked at as kind of, maybe beds occupied or space in ED used, etc. And then, possible perspectives, which I've already kind of spoken about. How you kind of look at resource use depends at which perspective you take. So from a society as a whole, or just directly from the NHS. So payer perspective in our case would be like NHS England or the ICB. They're the ones who kind of pay for the money. Healthcare, broadly speaking, we should probably look at the NHS and like personal social services. So like if you need social care and care input after discharge as well. And society would include both of those, and then the additional kind of indirect costs we spoke of before, lost productivity, and lost time, carer burden, etc. Commonly recorded items of resource use, GP or specialist visits, hospital admissions. When we take hospital admissions, we commonly look at ICD-10 codes and different bundles of costs, which might be diagnostic related groups you've heard of before. So you can be admitted with something simple like atrial fibrillation, and that'll have a certain cost associated with it broadly, or a much more complicated surgical admission, for example. Same with hospital bed days. The cost of staying in an ICU bed versus the cost of staying in generic medical bed or non-specialist unit will have different costs associated with it. And then kind of back note that resource use data collected in clinical trials may be of limited value for economic evaluations because of the inclusion of protocol related elements. So probably what they're trying to say there is that the randomized controlled trial is so controlled. For example, they might have additional episodes of care done in a specialist center, stuff which wouldn't really happen when applied to the real world. And it's not representative of what routine care is. In the same breath, if you're looking at a study done in one country, the standard of care, what's normal, you might be seen by physio twice a day in one country, but in the NHS, that's not really feasible. So you have to kind of look at what standards they were using for their own trial, and then keep that in your mind when you're trying to compare it to your own self and to what we'll be using the NHS. Then with resource use, how we collect that data on resource use, we kind of have our first-hand collected data, and then that can be validated or supported by other sources. So case report forms are kind of direct recordings of resource use done by the researchers at the time it was provided. I'm sure it's meant to be as contemporaneous as possible. So that's recorded, and then that can be supported by electronic health records, which should be available also. We have patient questionnaires, the structure of which as well will kind of really depend around what question you're asking. So if you were to ask somebody, how many times have you contacted or phoned your GP in the last year? It's a very difficult question to answer. And you might be better framing that by asking them, how many times have you called your GP in the last week? But then there could be other questions like, I don't know, how many times have you been admitted to hospital? Or, I mean, that might be hard for some person to answer, but even how many times have you been admitted to hospital outside of your area? You could ask them that in the last year, and you'd probably get a more accurate result. So you just have to be aware kind of how you frame the question. And I think this what kind of resource you're looking to measure with each question, and that's how frequent you're going to have to do the questionnaires. Patient diaries also can be recorded, or researcher diaries can record it as well. And then there's different literature, data sets, and public sources available and guidelines. And I think Valerio gave a link as well to a source called DIRM, Luís, but I forget what the acronym for DIRM is, but it's, I think, relates to kind of a source for you to find costings for resource use, I believe. It's on the notes. I can't see it here, but and then looking at unit costs. So it's a total expenditure incurred by a company to produce, store, and sell one unit of a particular product or service. And when the cost is not directly identified, the concept of opportunity cost may be needed to assess how to compute unit costs. How do you kind of compute the unit cost for an informal caregiver, for example? Opportunity cost as well. That is I don't know if we discussed it in the last one very clearly, what opportunity cost is, but there's a cost of a resource. We can see that, record it, but we also need to consider the money we spent in one place can't be spent somewhere else. So there's a opportunity cost basically associated with everything you purchase and everything you spend. And different sources for data unit costs can be the NHS reference cost, unit cost for health and social care, British National, the BNF as well, in there. And I think
I think that one was already mine, but
oh,
you were so excited going that I let you. No, let's just okay. Maybe let's just switch. Let me just share the slides. And thank you for doing an extra one. Oh, you are muted.
There, stop sharing. You should be able to take over now.
Yeah. So yeah, well, first, while we switch, can you see my slides?
Yeah, we can see it. It's just on the not on the full slideshow
Okay,
yet.
yeah. So let me just okay, so thank you, Ryan, for doing this first part and even one of my slides. But yeah, in the meanwhile, just ask people if you have any questions. Does anyone have any questions so far? I think to some extent it's pretty intuitive. We need to find these resource use and the price of it, and then we get the total costs. I think the issue is that resource use is not as simple as we might think, and this is the slide where we are going to debate about that. So Ryan already went through the slide, but I want to do something with you. That's why I'm coming back. So Ryan already explained you this so that we have the unit cost, which is the total expenditure incurred by a company to produce, store, and sell one unit of a particular product or service. Now, the thing is, and this is what I want to do with you, is how do we actually compute this? Because, okay, let's read it again. A unit cost is the total expenditure incurred by a company to produce, store, and sell one unit of a particular product or service. This is actually not as simple, because if I tell you, for example, let's pick this example. I'm doing an economic evaluation, so we are actually writing a paper on this, which is we have a technology that is a fall prevention technology for older people, frailer people living in care homes. Now, let's pick this example of this fall prevention strategy. We need to account for, if we want to know the costs of the technology. One part is pretty obvious, which is the cost of the technology, and that is basically the price that a provider charges for the technology. And in our case, that is not very difficult because the price is more or less fixed, and it already has into account maintenance and training. So the care home pays that, they get the technology, and that's it. Now, the thing is that the costs of the technology are not only the direct costs, the price of the technology. We also need to account for the indirect, as Ryan explained you, the indirect costs of the technology. And in this case, it may even be cost averted, because the technology is a fall prevention technology. Now, if you prevent a fall, people fall less. If people fall less, people don't have certain injuries. For instance, they don't fall, they don't break a hip, so they don't need to go to the hospital, so they don't need to use the ambulance, they don't need to use a room in the hospital or the physicians that need to take care of them. They don't need to maybe do a surgery, a hip surgery, to repair the damage that has been done. They don't need to stay in the hospital for a certain amount of time to get better. They don't need, for example, to then do rehabilitation. So when we compute the costs, not only we care about the costs, the price of the technology, but also we will subtract, in this case, in this example, the costs that the technology saves. Of course, if the technology produces any other sort of costs, then they need to be added. But in this case, we are talking about these ones that we want to subtract. Now, my exercise for you, and now I will need you to participate and to say things. My exercise is, let's pick the example of a fall prevention where you may have someone break their hip, and I want you to think about what are the resource use that you need to have into account to then try to compute the unit cost of hip fracture with the correspondent with the respective surgery. Okay, so yeah, please unmute yourselves. You can also write into the chat if you prefer, but I would prefer if you unmute yourselves and tell me what type of things, what type of resources do we need to do a hip surgery.
Hi, Louis.
Yes.
Yeah,
Brian?
so for me, it's the ED admission. So that will be ED resources, including the staff. Patient will be transferred to the ward, so that will be the ward resources, including pain relief, analgesia, if patient has infections as well, so that will require antibiotics, fluids, the intravenous fluids, and the staffing resources. Aside from that, I'm just basing this on the pathway for hip fracture care and the theater staff as well for surgeries, and then rehabilitation staffing up to community resources to continue for the rehabilitation.
Okay, but no, all of what you said makes total sense. So we also have, I can see here in the chat that OT time post-operation, rehab if needed, theater costs, and all of that is correct. But for instance, let's say we are going now to do a surgery. Okay, we have more. We have maybe loss of income, carrying impacts. We are going to go there. Yeah, that makes total sense because that is, you already saw because Ryan already showed you, but that's the next bullet point. So it will depend on the perspective. So now let's start with the healthcare perspective. So what the NHS has to pay for a surgery. So Brian already gave us a very good pathway, but let's say we are now in the room and we are going to do the surgery. What we need to account for. So someone, please, I can start. We need the surgeon. So that's my contribution. So, okay, anesthetics, theater time. Theater time is I would assume is the time of doing the surgery. Is that correct? Okay, thank you. So anesthetists, sure, yeah. So we have the surgeon, so the person that does the surgery. So we have the person that needs to do the anesthesia. ODP, what does it stand for? ODP staff?
The operating department practitioner, I think.
Okay. Thank you so much, Jane. So yeah, we need all the staff, for instance, the nurses as well, helping with the surgery, or nurses or other doctors. I'm so bad. You will understand. I don't understand that much of how actually things work sometimes in the hospitals. So operator department, so PPE and wider equipment. So equipments, yeah, you need from the basic stuff as what is the name of it? Bistri, to cut. So all of the instrument that you need. More. You are still missing some things. So yeah, we already have the staff or clinical waste cost. Yeah, makes total sense. The cost of a bed. Yeah, even though the cost of a bed is tricky, yes, but I would frame it in another way because the cost of the bed is the cost of equipment of having a bed in there, but I would say it's mostly the cost of a room, of using a room, so for the person to stay. So I would say like capital costs. You have a capital cost of using the capital, the space, the hospital space, the room, to have someone there recuperating, recovering, and that is basically yeah, it's a capital cost. What could you have been done with that room if you were not using that room to have a patient in there? So the opportunity cost, the cost of capital. Imagine that you were using the physical space of the hospital to do something else, some other business. That would be the opportunity cost of the space used. So what else? So other operations that cannot take place whilst the operation is taking place. So it's kind of the opportunity cost. Yes, so it's the opportunity cost of the space. So is there an estimated available cost of intervention per type of intervention available that hospitals are able to spend per type of intervention that will be covered by the national system? I'm not sure I understood. So is
I'm
there
asking because I'm originally Polish, so I know the Polish system a lot better. I'm not a medical professional. I actually work in public health. So my question is there like a charging, basically like a charging sheet where you know how much a typical intervention is estimated to cost in a given national healthcare system? I know the Polish healthcare system has got those estimates, so you actually know and can learn what is being kind of, accounted for, if you like, and what that means, which is slightly easier as a way to kind of learn what such costs are, isn't it?
Yeah.
So it would be great to know if something like that, from
No,
my
exactly.
perspective, something like that exists.
No, that is a very good question, and that is exactly the conclusion of this exercise, which is the unit costs. What you are talking about is the unit costs. So what I'm doing right now is I'm just disentangling the unit cost and saying that when you have, let's say, hip surgery, in this case, you will need all this stuff. You will need the surgeon, you will need the nurses, you will need the anesthetist, you will need the equipment, you will need the room, you will need, so someone was writing cleaning and sanitizing. You will need something that I think no one said yet. You'll need light, you will need water, you will need the staff that are basically managing the hospital. And you need from all of those costs that you need to account for when accounting for the costs of this hip surgery. You need to find an average of how much this will cost per hip surgery. So summing all of that, you check several hip surgeries and you try to find the average of how much a hip surgery is going to cost. And that is the unit cost. So usually in an economic evaluation, you won't see, again, a hip surgery, you will see already the unit cost. So you will have certain hip surgeries were avoided. In my example, it's a fall prevention strategy. So the idea is to find that the fall prevention intervention reduce the number of falls and therefore reduce, let's say, the number of hip fractures and the number of hip surgeries. And then you go precisely to some unit cost resources and you find already what is the average unit cost of a hip surgery. And then you have the amount of the number of the number reduced, you have the cost, and that you can compute how much in terms of money this fall prevention technology saved in terms of hip surgeries. So yes, I think so. I was just doing the exercise for you to understand what is behind producing this unit cost, is understanding every single part of these costs and then trying to understand how much hip surgery is going to cost, checking the average on average, because you have several. You may have a hip fracture that is a little bit easier and that costs not a lot, but then you may have a hip fracture that has a bit of complications. Maybe the person is a little bit older, a little bit frailer, and it's going to be slightly trickier and it may cost a little bit more. Of course, from person to person, you are going to have slightly different costs, but on average, you can compute an average and get the unit cost for the hip surgery. So let me just check the chat. Do you choose the most common type of fall outcome and how, if at all, do you account for other possible scenarios? So no, I was just using the example of the fall to tell you that the fall may cause a hip fracture, and that then you can cost the hip fracture episode. Let's say I was just using the example of a surgery. So yeah, then it will depend on what resources do you use. Sometimes you go to the unit costs. You may have even the unit costs by severity. So you may have a hip fracture and different levels of severity. And if you find that for a certain level of severity, they cost a little bit more. And if you believe that in your example, in your economic evaluation, for some reason, people did have the most severe one, you may count the costs of the most severe one. If you admit that they are the average one, then yeah, the most common one, as you wrote, then you may count that most common one, that average one. So just one thing that I think I missed, which is, for instance, if you need to account for the building, the opportunity cost of the building, if you need to account for the time of the surgeon, if you need to account for the staff that you need to run the hospital, human resources, etc., you will see that the time. So you need to find the allocations to the hip surgery. For example, the surgeon is quite easy. Is just you, for instance, try to find the average time of hip surgery, and then you have the average time that the surgeon is going to spend on a hip surgery, and you can just multiply that amount of time by the price, the cost, the salary, let's say, of the hourly salary of a surgeon. But for instance, in terms of water, in terms of electricity, in terms of the staff that is just the human resources, the other stuff that is not directly involved in the surgery, how do you account for that? So that's actually not a very easy question, but it's just you try to, let's say, that you imagine, just to simplify it, imagine that is a hospital that only does hip surgeries. Then you would divide all the costs of staffing, etc., by the number of hip surgeries that you do. Okay, so probably what you are going to do, so you know that you have staff that is there to receive the patient, staff that is working on human resources, other type of stuff, and you still need to account for those costs. You probably divide by everything that is happening in the hospitals, all the events, all the surgeries, all the stuff that is happening in the hospital, and you try to allocate a bit of it to the hip surgery. So the same with light, water, etc. You know that of course the electricity is going to pay for everything, but you need to try to understand that amount of time that you spend doing the hip surgery. So how much should you input in terms of the electricity and the water, etc. So
could I sorry, could I share some reflections on that as well, just because it's we work on that. That's kind of part of my role, and I don't know whether it'd be helpful to kind of share some reflections on that as well. We may look at things slightly differently if that's also part of your role as well. Sorry, I came in really late.
No, please.
And I'm going to look back over the recording, but so I've kind of just come to the end of a business analysis course, and as part of that, I was doing a lot of cost impact analysis. So it's really, really complicated, basically. So to answer your question from earlier, sorry, I'm a Sinska 002. Sorry, I'm not sure of your name, but so it's really hard, basically. So you have, as Luís said, there is the unit cost that procurement will be able to kind of tell you what that is. According to the contract. There's then also the tariff income that you get in, so that's going to be offset. So my role as innovation officer, so we'll be bringing in new products that will have a different unit cost to normal. So obviously the tariff income, which they're not generally they're not always logically priced tariff. Sometimes something is much better and the tariff income will be much worse for it, which is terrible because it incentivizes complex, much more invasive surgeries. And you have to find all of this yourself. There is no information to bring it all together. So then in terms of theatre's costs, there are, I mean, as you will have picked up from what Louisa said, there are so many different methods of getting it according to how good your organization is, basically, with clinical coding. So everyone in every theatre will have slightly different ways of writing notes, even if there is a standard way of doing it. So they will some of the surgeries won't even have a surgeon recorded as being in attendance. So you are dealing with quite poor quality data in that clinical coding, which is difficult because each service is going to be slightly different, each procedure, and the way that each trust manages each procedure, who they've got in there. Do they have a circulating kind of theatre nurse? Do they have this? Do they have that? It'll be slightly different. So in terms of staff costs, again, even though you can look up, what's the average band, what's the middle pay for that band, the difficulty then comes in with even knowing exactly who is in the room. So that can be really hard because obviously it's a much bigger team that's always in that theatre rather than just the surgeon. And then the way that once we've got the best quality that we can possibly get of all that information, the way that we look at it is, which I think is the easiest way, because obviously, as Louis said, each surgery will cost slightly different depending on how complex it is because of how long it takes, etc. However, what we tend to do, which I do think for most of the time is actually probably the most logical way to do it, is to look at the average number of patients that can be seen in each theatre session, because each theatre session will always be, and that's for that particular procedure. Because each theatre session is always going to be the exact same amount of time. That surgeon will book out that room for a set slot, which is, generally half a day or a full day. So I think it's like, 4-hour blocks at a time, or it'd be 8 hours for a full day. So that generally is the kind of most straightforward way if you're trying to look at how much a procedure on average costs for an organisation. It would be, almost impossible to say how much each individual one costs, because, for example, a really complex procedure could take 2.5 of those hours out of a 4-hour block. That actually means that you're not going to be able to see another patient for that because they've run over. So that actually, then they cost 4 hours worth of theatre time. So because that's money you're not getting back. So depending on, and again, these booking systems might be different. Just to throw in a bit of fun, each hospital might be slightly different in terms of how you book it. So that's something that's really important to know as well. And if anyone does want me to continue my rant at any point, do let me know. Like I could go on with more detail, but I know I've kind of derailed for a few minutes now. But essentially that's how we've been approaching it in our team. And obviously like that process might change through the course of this course. But yeah, it's hard.
So this is completely wild, because you've just, for me, thrown a spanner in the works, where it kind of tells me that no matter what the tariff might be saying, right, and what the kind of national tarificator kind of assumptions are, actually the realities that are uncovered by each organization kind of on the ground might completely belie that. And they're based on things that you've mentioned, like the coding quality and and your kind of local practices. That is really interesting. But yeah, it is probably completely sidelining everything here. But it just goes to show that sometimes, things that we assume are kind of true at a wider picture level actually might, practice might completely tell us is not the case.
Thank you so much, Katie. But one thing that is important also for you to understand is that we look at things on average. And yes, looking at things on average means that sometimes it may be slightly off, it may be overestimating, underestimating, but on average, hopefully, it will capture the essence of it. That's what we hope. If the methods are correct, they should. Then, of course, if we have, as Katie was explaining, sometimes things may not be accounted so accurately as we would like, then mistakes can happen. But yeah, unfortunately, we can only do the best we can with the data that we have. And yeah, it's better to do something than doing nothing at all. So okay, just continuing. We don't have a lot more time in this session, so I'll just continue. But we should have enough. So okay, we were looking at the hip surgery from the let's say NHS perspective, but I saw in the chat some people were already talking about, oh, okay, what about informal caregivers and their time? So yes, if we want to go for a societal perspective, we could potentially compute the time that the caregivers, the informal caregivers, spend with the patients, and we could, for example, then try to find the number of hours that they spend with them, and then try to cost it either using the average salary or sometimes the minimum wage. It depends a little bit of the assumptions, but then you try to find a price for that and you can compute it. Now, Ryan already showed you some examples of sources of unit costs, and I'm going to show you a more specific example. So for instance, at some point in my research, I was trying to find the cost of a social care worker. And yeah, the good news for us is that we don't have to find all the things, all the details, because hopefully in these resources that I'm showing you, we already have the final price for it. But let's see again in detail, what do they account for when they compute the social care worker costs, unit costs, and the obvious part is the salary. Okay, so we have the salary. I don't think I have to say much about that. Then another part is still related with the salary, which is the on costs such as national insurance. So that part pretty obvious as well. But then we have in this C, initial qualifications. So depending on whether they have had some sort of training or not, they may cost a little bit more, and that needs to be accounted as well. Then there is a part here, an item here for ongoing training. So they don't put actually any price in there, but just showing you that potentially if they believe that there should be some ongoing training for these types of workers, then you should account it as well. Then we entered the overheads department. So that part, when I was giving you the example of the hip surgery, where I was talking about the water, the electricity, gas, and then the other types of professionals that work in the hospital as well, just to make the hospital work. So here we can see that the direct overheads. So let's read it. Direct overheads include costs to the provider for administration and management, as well as for office, training, and utilities such as water, gas, and electricity. Then indirect overheads, which include general management and support services such as finance and human resource departments. Then there's still the capital overheads, which will be probably building related. So based on the new build and land requirements for local authority office, and shared facilities for waiting, interviews, and clerical support. Capital costs have been depreciated over 6 years. So this is just a little bit of methodology on how they depreciated the capital cost. Then there could be traveling. In this case, there's nothing, so no information available, but it could be there as well. And then you sum all of that and you get the total costs. So this is our total cost for a social care worker. Now, you can do it per year, or if you want, you can do it per days, per hours, or per week. So in this case, we have the working time, and you can compute either the working time again per days, per hours, or per weeks. If you divide the total cost by one of these, you get the total cost per day, per hour, or per week. In this case, it's more common to do it per hour, I think. So in this case, you can see that per hour with qualifications, which is the one with this part here, is £53 per hour, and without qualifications, it is £44 per hour. Now, I'm going to go to the example of the first RaCEEs that we did, just for you to see how to check it in your papers that you are analyzing. So in this case, so Raj et al. Is ours. So we have that the model considered both medical and non-medical costs, including hospitalizations, emergency room visits, consultations, professional caregiving, and respite care. Health state costs were estimated using regression analysis. Professional care accounted for a significant proportion of the total costs, with the cost of nursing home staff being the most significant factor. Then if you go to the methodology section, about the costs, in the cost section, we could find this first part here. I'm not going to read it all, but this is about the LCGI treatments for Parkinson's disease. And this part here is going to be mostly about how much it costs, the technology itself. So the average daily doses. So this is standard of care medication as observed. So they talk also about the standard of care. How much do you need to spend in the standard of care? So this first paragraph. Then you have the LCCIG. So included startup costs such as, I'm not going to read everything, but they detail it. And then you have the costs associated with the health states. This is a Markov model. So that's why you have the health states, and you need to have the costs per each of the health states. And they will tell you that, I don't know if you remember, but we talked about the HY index, which is basically a measure of severity of Parkinson, and also the off time, which is another measure of severity of Parkinson. They used both. And then depending on which stage you are in terms of the HY index and in terms of the off time, there would be costs associated to it. And you can see that the health-related costs include direct medical costs, such as hospitalizations, emergency room visits, and consultations, but also direct non-medical costs, such as professional caregiver and respite care. Then at the end, we have I think this is just a summary. The total cost represents the combined costs for all variables. A great proportion of the total cost was associated with professional care, comprising home help, therapists, and nursing home staff, with the cost of nursing home staff being the most significant factor. So again, you see that they have a lot, and we need to understand a lot to then just write a little bit. But again, as I told you, we will also need that for the commentary in order to do the appraisal. Now, let me just check the time. We still have 10 minutes, so we should be fine. Just an example of the costing table of the paper. So you will see precisely as Brian explained you. So we have LCIG is the new technology, and SOC is the standard of care, so what you had. And you are basically going to do the resource use and the costs for both of them. So medication, we start here with the LCIG, and we have the unit cost. So they explain that 2 cassettes are required per year, if I'm not mistaken. And then you have the cost, and they have the cost of a cassette equivalent to, they have the annual equivalent. So I assume that the cassette works for, let's say, 2 years maybe, and then they have the annual equivalent. Then other medications, you have here the resource use, which is concomitant oral medications, including COMT inhibitors. And then in this case, other medications are for the standard of care. No, they are for both. Sorry, they are for LCIG. So this part that I read. And then for standard of care is oral medications, including 2.26% patients taking appropriate morphine. Sorry, and then you have the respective costs. So you have these annual costs, 319 for LCIG, and you have these 1,000 and something annually for the standard of care. That if you continue, you will see that the LCIG startup, you need this tube insertion, you need this PEG tube insertion, you need this titration and monitoring, and you have here the resource use, one of each, and then you have the respective cost in here. Then follow-up visits, you have the estimated follow-up visits, and then you have the costs. Then here for standard of care, we have the per visit follow-up, and then the resource use and the cost. Then per visit follow-up non-consult led, both for LCIG and for standard of care, and the respective costs. So you see that basically it's what we said. I'm missing also the adverse event, which can only happen, if I'm not mistaken, in LCIG. So you have the resource use. No. Or is it? Yeah, LCIG. And then you have the prices. Okay. Now, I'll leave this slide to Ryan.
Thanks, Luís. That's great.
And the rest of it to Ryan.
Do you want me to share my screen?
No. I can skip.
You could do it. Perfect. That's easy. So yes, if we look at currency and price here, and this will actually tie into a question in the comments from Brian. We'll talk about it a bit first. So common currency. First of all, when you're trying to compile costs for an evaluation, you have to have a common currency, and typically in international studies that would be put back to dollars most often. And in the same instance, you'd need a common price here. If you imagine we're doing a Markov model, let's say Luís again went back to that example of Parkinson's, and you're trying to do a cost of a health state. If you're taking kind of information from different sources that have been studies done in different years, you can't just take the costs as they are. You need to kind of account for inflation. So you need to make sure that the cost associated with a study done in 2010 is relevant to now. So you basically convert them to US dollars and then convert them to the relative price. And here you might see an example that it will say something like all costs were converted to US dollars and the price year was 2020. Brian asked a question about unit cost being dictated by current market. And yeah, so to an extent, current time frame you would adjust for inflation, but if there's something gone on probably external to just general inflation price rise, like something geopolitical like Strait of Hormuz or something like that, I don't know if you'd get a direct update, and you'd probably just be hopeful that the people who do, like the BNF for example, will give kind of regular updates as to how much it costs, or the different websites we go to find prices, and will be updated regularly.
Yep. Just one note that, for instance, if you believe that in certain regions the prices are, for instance, let's say smaller, that's also something that you need to have into account when you are doing your appraisal. If a study did something in one region and they do the costings for that region, maybe if you extrapolate it to another region, maybe the cost will be higher as well. So that's something that sometimes needs to be adapted.
Yeah, absolutely. Like take the US, the cost of everything in the US, just with the way their market works, is so much higher. So you'd have to account for them all. Good. And then
let me just show something, which is, for instance, here we have in the paper that these unit costs reflected the 2017 evaluation. So precisely as Ryan was just explaining, we also always need to put everything to the same, comparing apples with apples. So same years, we need same currency. We need to adjust it. So yeah, please, Ryan.
Any questions, anybody on that? Or happy with that as well? Perfect. So then homework, yes. So Valerio has done the usual. The date for the homework is to be done by the 30th of June. And then if Luís goes through the next slides, I think it shows where Valerio has uploaded a new folder onto the channel. So once you go into that, you should have individual sheets for everybody. And then the actual worksheet itself goes through kind of what we're talking about relative to your piece of research you're looking at, your source, and kind of just an important note back that the cost data should be in the methods or the results tables. That's 90% of it. You might find sometimes they've got stuff in appendices as well, and kind of additional sources at the bottom, which is also worth looking at. And yeah, just kind of work your way through and come to us with any questions. I'll do any of that.
I'll probably email you because the Teams channel has disappeared for me. So I don't know whether it's an issue with, we've had some org change recently and it's had some IT implications, but I'll probably email you at some point about that.
Maybe,
Okay.
yeah, maybe you need another invitation. So email us and Valerio as well, because Valerio is usually closer to the team that can help with that. Yeah, and we'll try to solve that. If not, if for some reason you are not being able to see it, just tell us and we can send it directly to you, the homework. Yeah, so maybe we'll do that. So email us and yeah, while Valerio tries to solve that, maybe we'll send you directly the file.
Brill, thank you.
And then session 4 is 29th June, same time again. And
Yep.
I think that's, yeah.
Yeah. I think
End of the session.
that's it. Thank you so much.
Thank you.